Okay, hello everyone and welcome to today's webinar for mental health professionals, optimizing exposure therapy for youth with complex comorbidities and presentations. My name is Sasha Sicard and I am the Education and Membership Manager here at ADAA. Thank you all so much for joining us today. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. For those who have applied for CE or CME credit, you'll receive an email within 24 hours with the link and instructions for completing your credit requirements. If you do not receive this, please email me directly at sicard@adaa.org. You have all joined the presentation today as a participant, and as such, you will be muted for the duration of the presentation. We've taken a screenshot of an example of the attendee interface that you should see. You will have the opportunity to submit text questions through the Q&A feature featured in the attendee interface at any time. We will collect these and address them at the end of the session with our presenters. I would now like to introduce our wonderful presenters, Drs. Emily Becker-Hames and Hannah Frank. Dr. Emily Becker-Hames is an assistant professor at the University of Pennsylvania. She is an implementation scientist and clinical psychologist dedicated to improving mental health care for youth. Dr. Becker-Hames' research focuses on treatment optimization for pediatric anxiety disorders. As the clinical director of the Pediatric Anxiety Treatment Center at Hall Mercer program, which is the only specialty anxiety clinic in Philadelphia dedicated to serving youth in the public mental health system. She has trained hundreds of clinicians in the application of exposure therapy. I'd also like to introduce Dr. Hannah Frank, who is a postdoctoral fellow at the Warren Albert Medical School at Brown University and at the Pediatric Anxiety Research Center at Bradley Hospital. Dr. Frank's research and clinical work is focused on exposure-based treatments for anxiety disorders and obsessive-compulsive disorder. Dr. Frank has clinical experience working in several settings treating youth with anxiety and OCD, including an outpatient clinic, a community mental health center, and a partial hospitalization program. Thank you, ladies, for joining us today. There will be a brief moment of silence while we pass over the presentation role to them. Dr. Becker-Hames, you can go ahead and share your screen.
Thank you. All right, is that looking right to everyone? All right, thanks, Hannah, because here's the face I can see. Thank you, everyone, for joining us today. We are very excited to talk about a topic very near and dear to our heart, which is really about how to think about approaching and optimizing the use of exposure therapy with youth who are experiencing anxiety alongside other complex comorbidities. Thank you for that wonderful introduction. We wanted to start off just by elaborating very briefly about our clinical backgrounds and why we're so interested in talking about this today. So as mentioned, I direct the PATCH program, which is dedicated to serving youth in the public mental health system. And we almost always are seeing youth who have sort of relatively complex presentations who may not benefit from the use of traditional exposure therapy alone. And that informs a lot of what we'll talk about today. And now I'll turn it over to Hannah to introduce herself.
Yes, again, just adding briefly, I did also work at PATCH with Emily when I was in Philadelphia, and now I'm at Brown and I work at our partial hospitalization program for kids with anxiety and OCD. And so a lot of the examples that I'll draw on today will be from that experience of working with kids who get 30 hours of treatment a week. And so, of course, there's a lot of complexity in these presentations. All right, so before we get started, I will give a brief overview of what we're talking about today. And importantly, today's talk is really just the tip of the iceberg. So Emily and I have done many trainings on exposure together, and we always find that there's not enough time. We could spend 15 hours on this topic alone, but we'll try to touch on the key points within the time we have. So we'll start with just some brief background and exposure to orient everyone to the topic. And then we'll delve into a 5-step approach to exposure to break down each of the components. And then we'll switch to really talking about how we tailor exposure among youth who have comorbidities, and then finally leave some time at the end for Q&A. So as many of you already know, exposures involve gradually helping people face their fears. And so although, Emily, do you mind advancing? Actually, you can just do, well, Okay, that's good. We'll just leave them all up. We'll skip the animation. So when we talk about exposures, we're talking about gradually helping people face their fears. And the purpose is to teach clients to tolerate their fear and to learn that their brains and their bodies are safe and can handle it. And so this is a photo of Emily doing an exposure of holding a tarantula, which is really a story for another time. But the very brief version is that when she and I attended a tarantula handling training together, she successfully completed some gradual exposures leading up to this photo in which she is smiling, a little bit of a scared smile, but she did it. And I think, although this is a success story, one thing we know is that it can be very challenging to do really good exposures. And that photo on the left is sort of more maybe what common perceptions of therapy look like, that it's this comfortable, safe space where you're laying on a couch discussing emotions. And probably, as most of you know, exposure can feel like a contrast to that because we're actually asking clients to engage in things that are really challenging. So even though we always do exposure in a supportive, collaborative way, a lot of therapists have worries and negative beliefs about doing exposure. And this makes sense because it's hard to ask people to do hard things. So one thing we know is that given that doing exposure often brings up this anxiety for clinicians about asking people to do hard things, it might not be surprising that exposure is not used by a lot of people in routine clinical care. And although there are significant research to practice gaps for a lot of evidence-based practices and treatments for presenting problems, exposure really lags behind other practices. And it's often considered to have a public relations problem, with many clinicians expressing worries that by inducing distress intentionally, exposure violates the principle of doing no harm and is unethical. And other research has found that it's the least used evidence-based intervention strategy and the most difficult to implement. So even after people learn about CBT, choose to engage in trainings, only about a third of them who identify as CBT clinicians report regularly using exposure. So we know that it's hard to use. And one of the things when we think about how to support clinicians in using exposure, which is the focus of a lot of Emily and my work, we're increasingly recognizing that how to effectively deliver exposure is a bit of a black box. So we have this need for practical tools for clinicians to address barriers to delivering exposure, because there are all these things that come up, like what if an exposure is way too hard? Or what if every attempt at an exposure elicits no anxiety? Or what if the person has another presenting problem that arises during exposures? So we don't have a manual that tells us exactly what to do in these situations. And we also know that there are a lot of other barriers to implementing exposure, like difficulty generating ideas, not being allowed to leave your office. And these all make it difficult to deliver exposure, especially with complex cases.
All right, so there are some core principles that are really based on what Hannah was sharing that are associated with the difficulty of delivering exposure that are going to guide our talk today. So first, we know that exposure is complex. So we think it's important to try to break down the process of delivering exposure therapy to make it as easy as possible for clinicians to deliver it. And second, we want to acknowledge that we as a field as a whole don't always do a really good job at recognizing that it can be really, really hard to deliver high quality evidence-based treatment, including exposure, outside of specialty or highly resourced settings. And third, we need to be really open that there are limitations in the treatment literature about knowing exactly for whom and at what points in treatment exposure should be used to be most effective. And so we're going to try to address each of these 3 points in a short amount of time. So toward the first point, we're going to try to distill the complexity of exposure into a 5-part model that can be used as a distinct intervention in tandem with other treatment techniques. And to the second point, we're going to explicitly discuss and acknowledge how comorbidities can and will impact exposure treatment. And finally, what we hope to do is provide some practice-based clinical guidance to everyone here today about how we can begin to approach exposure for complex cases. So we're going to start into diving into the 5 steps of exposure that we've outlined. So first, we will propose that a solid case conceptualization to understand who and how youth will ideally benefit from exposure is key. And then we'll break the exposure therapy process into 4 steps: psychoeducation, assessment and hierarchy building, individualized practice, and homework and relapse prevention. It's important to keep in mind that for each of these parts that we'll be talking about, they're not necessarily reflective of a linear process, and each part is likely to be continuously revisited throughout treatment. And so in the next about 15 to 20 minutes, we're going to briefly review each of the 5 steps. And then after we finish that overview, we'll turn our attention to discussing how this can play out when there are complex comorbidities at play. So we're going to start by diving into the case conceptualization component. So you may have heard this phrase before. It's like, if somebody has anxiety or OCD, we should do exposure. And there's a growing literature devoted to the importance and practice of science-informed case conceptualization that sort of lies behind this concept that we don't have time to cover here. But briefly, accurate detection of target problems is really how we can identify what our clear roadmap is for understanding what treatment should be used. So if somebody has a particular diagnosis like anxiety or OCD, then we would have very clear evidence from the literature that because of that diagnosis, we can then assume that exposure therapy should be an effective treatment. And this is really most compelling when it comes to anxiety or OCD. One of the reasons that I love doing this work is that it's one of the most effective treatments that we have out there for kids. And so it is one of the most strongest empirical tradition that we have. So if you've heard the maxim, if you have anxiety or OCD, we should do exposures, you're not alone. We hear that a lot. And that's for very good reason. So here on the slide, you can see multiple ways that anxiety and related disorders can present that we know exposures can be effective. When youth present with one or more of these conditions, we have very good reason to believe that exposure should be in the forefront of our treatment plan. However, sometimes this isn't so straightforward because these disorders or symptom presentations, as many of you likely know, can often occur in the context of other comorbidities. And while this doesn't negate the potential for exposure to be helpful, it does make it trickier. And as we have mentioned, this can be particularly complicated when there's multiple comorbidities or other complexities at play that can alter the approach. And we're going to circle back to this after we go through each of the next 4 steps of exposure. So we're going to begin with the traditional exposure model for this more traditional classic anxiety, and then talk about how to adjust and conceptualize our approach in more complex presentations. And I'll turn it over to Hannah.
All right, so Emily and I have done a whole separate talk on psychoeducation. So again, I could spend the whole time here, but I'm going to just run through it quickly so we're all on the same page in terms of sort of the principles we'll be referring to throughout the rest of the talk. So for the purposes of this example, I'm going to use dog phobia, though again, as we'll talk about, I want to just acknowledge up front that very rarely, if ever, do we get cases who have just a straightforward phobia. But for the purposes of this example, if we think of somebody who has a fear of dogs, if they know that they're going to be somewhere where they might see a dog, what happens is that their anxiety goes up and up and up. Right? And eventually it hits a point where they feel like they can't handle the anxiety. Maybe they're even just going for a walk and they hear a dog barking and they hit a point where they're like, I can't keep walking that direction because the dog is barking and if I can't go near a dog, that's too scary. So suddenly they turn around and they start walking home. When they do that, their anxiety goes from being up way up high to dropping down because they walk away from the barking dog. That's avoidance or, a safety behavior. And in the case of OCD, it could be a compulsion, and that drops the anxiety and gives you quick relief. That quick relief works really well in the moment. And then the next time they go home, they feel good. They don't have to hear a barking dog or be near one. But the next time they go out for a walk, anxiety comes back up again, right? And they hear that barking dog and they run back home. They don't go for their walk. They get that quick relief again. That escape, that's the negative reinforcement of how they feel better after leaving a situation. So this cycle repeats itself over and over and over again, and until potentially the person's doing even more avoidance. Maybe they're not even bothering going outside because they know they're going to hear a dog barking and go home. This is the cycle of avoidance. You avoid more and more things that bring up that feeling of anxiety. I always say it works really well in the moment, and then it gets you trapped and confined to your house. Maybe literally, maybe not. So then when we think about exposure, we talk about breaking this cycle of avoidance. And so what we do is that rather than doing that quick avoidance or escape behavior, we go into the anxiety provoking situation, maybe start going for a walk, you hear a dog barking. And instead of running away from it, when you hit that peak, well, what happens is anxiety tells you, you can't handle this. Your anxiety is going to go way up high off the charts. I have one client right now who I say, you might explode into a pile of sprinkles and you just won't be able to handle it. The reality is what we find is if you stay in the moment, it doesn't mean going up to the dog. It means maybe just staying on the sidewalk, hearing a dog bark in the distance. You're not going to explode into a pile of sprinkles. You're not going to lose your mind. You're actually, the longer that, if you actually stay there, eventually what will happen, you can't stay in that fight or flight mode forever. Your anxiety will eventually come down on its own. And then we say what this really looks like is not this beautiful smooth trajectory down. Habituation actually usually looks more like this, where it gets a little easier, then a little harder. The dog barks louder, it gets harder, then it's quiet, it gets easier. It looks more like this, but over time with repeated exposure, your anxiety comes down. It doesn't even get as high. The peak isn't even as high. And so this is, the more that you do it, the easier it gets. Your anxiety comes down. You learn that you can handle it. You can tolerate the situation. This is the basic model that we use to present, and I present this exact model to patients. And part of the reason we're presenting it to all of you is we're going to come back to this model and why it doesn't always exactly, of course it's theoretical anyway, but it doesn't always exactly apply, especially for kids with complex comorbidities. Okay. So once the child and caregivers have some understanding of how anxiety works and how we fight it, we shift into a more in-depth assessment of the specific anxiety symptoms and fears and how we might address them with exposure. So I usually start by creating a list of feared situations, wait to create the list of feared situations, also known as a fear ladder or hierarchy, until I've done the exposure model, which I showed in the previous slide, because I want the hierarchy to include not just situations that elicit fear, but also situations that focus on reducing those avoidance behaviors, which could also be safety behaviors, having parents nearby, having certain objects. Maybe if a child has a separation fear and worries she'll get hurt away from mom, having mom nearby is a safety behavior. And so we would want to have different exposures that have the option of being far away from mom and maybe also not getting reassurance from mom as well, right? Reassurance might be a safety behavior. So just to carry out this example a little bit further, let's say that mom goes into a separate room from the child after promising or reassuring the child multiple times nothing bad will happen. This will probably be an easier exposure, lower on the hierarchy, than an exposure where mom goes in a separate room from the child and doesn't answer questions. And then it might even be harder if mom says, I don't know, something horrible could happen to me, right? So we think about both the exposure piece in terms of being away from mom and reducing reassurance, safety behaviors, avoidance. So in creating a hierarchy, we want to take this into account. And a hierarchy can be made in a lot of different ways. There's really not a right or wrong way, but there are some key ingredients. So you should always make sure you understand the core fear. And again, this is something especially important when we have really complex cases, that we want to know what is the feared outcome. If a child has a hard time being away from their parent, is it separation anxiety? Is it that something bad will happen to mom or kid when they're apart? Or maybe is it actually about social anxiety and the kid is afraid that they're going to get rejected? And as long as mom is nearby, they have somebody to go to. So it's always important to understand what is the core fear, what's the worst thing that can happen essentially. And then with OCD, I often use islands because they're usually multiple obsessions, and then we can connect all the compulsions. Again, the topic of another talk that we don't have time for today. But just two other quick things I'll say about fear letters. One is breaking situations into small steps to have a sense of how to make exposures easier and harder. It doesn't mean it has to be exhaustive. And then using fear ratings of any kind. It could be numbers, it could be pictures of faces. Again, more just to have a sense of what's easier and harder, not because you have to complete every exposure in order. And as I mentioned, actually I didn't mention this yet, but the exposure is the hierarchy is a living document that's constantly evolving. And so we're constantly evaluating, assessing, updating the hierarchy or the fear ladder based on what we learned from treatment and as we progress with exposures. And so especially when working with kids, it's really important that we know that baseline is a guide, and then we get information from other people, parents, maybe teachers. We also use behavioral observations to understand how difficult an exposure is. So if a child is grimacing, looking away, they say it's a 0, it's probably harder than that. And then using comparison questions, like would it be harder to call someone you know or call a store and talk to someone you don't know, depending on the kid, it may vary. And finally, even if you know the core fear, it might change, or you might actually just learn more about it over the course of treatment. So one thing we know from our experience working with a lot of different clinicians doing exposure is that the process of generating a hierarchy and exposure ideas can be difficult, especially for clinicians who don't work with other exposure therapists. Emily and I even have a text thread where we text each other exposure ideas. And if you don't have somebody you can do that with, then it can be challenging to generate ideas. So Emily led the development of this resource, which is called the Ready Toolkit, and includes pre-made exposure ideas that can be used to guide hierarchy development. And each of these, excuse me, these exposure ideas also address common barriers to using exposure, like not being able to leave an organization's building with a client, which is something we often encounter with the clinicians we work with. And so it includes specific ideas that can be done in the context of these limitations. So again, I have now said it and I will say it again. The hierarchy is a living document, and this is so important that especially if you're using a resource like the Ready Toolkit as a starting point, it's important to just remember the hierarchy is constantly evolving. It's not static. The other thing I'll say is that sometimes it's effective to be really broad with a hierarchy at first. So maybe just comparing phone calls versus emails for someone with social anxiety. And then when you pick the topic, then you can go into greater detail. If you decide we're going to start with email exposures, then you can decide, is it easier to send an email that you'll get a reply or you won't? Is it easier to send a question or just a statement? So there are a lot of ways to make hierarchies. There's not really right or wrong, as I said before, but I think one of the most important things, and especially when we learn about comorbidities and how they interact with anxiety, is to be flexible and know that the hierarchy is a living document.
All right. And so once you've gotten some buy-in from the youth and family and have a good sense of the core fears and the types of situations that are easier or harder for a given child, the next step is the actual exposure practice itself, or what we refer to here as individualized practice, really underscoring the importance of tailoring the exposures for the specific difficulties a child's experiencing. There are multiple forms of that exposures can take, and here we'll distill it down to what we sometimes affectionately would call the 3.5 types of exposure. So the first are imaginal exposures, where feared stimuli are imagined or scripted out. And these are most commonly used to either conduct lower level exposures or exposures to stimuli that might be difficult or even unethical to replicate in real life, like fear of someone breaking into your house, right? We're not going to have someone break into a house to have a kid practice getting over a fear of somebody robbing their home. Or this can be also used oftentimes for fears like fears of going to hell or fear of someone dying. And these can also be another way to kind of circumvent some of the organizational challenges if there's things that you can't do or be able to get at outside of the building. Imaginal exposures can be a very useful tool. And then in vivo or situational exposures are probably the most common. And these are really involved, that's really getting out and doing things and kind of really coaching kids in sort of real life situations as much as possible to help kids get out and do the things that they're afraid of and help them box back their anxiety. And then interoceptive or sensational exposures are really drawn from the panic disorder literature, but increasingly are being used more broadly with youth with anxiety. And these involve really intentionally bringing on the physical symptoms of anxiety to help kids learn to tolerate those physical symptoms and reduce the avoidance of the physical sensations that can be very uncomfortable that are associated with anxiety. And finally, the last item we have here is exposure with response prevention, or ERP. And ERP is most commonly associated with the OCD treatment literature and refers to the notion that one might, intentionally bring on exposures related to intrusive thoughts or obsessions, and then work to prevent themselves from engaging in responses. So that's the response prevention component. However, since non-OCD anxiety is really most often associated with avoidance behavior, similar to the psychoeducational information that Hannah presented earlier, and what we're ultimately always trying to do is help prevent youth from engaging in avoidance, safety, or compulsive behaviors, we can think of exposure and response prevention as the same thing conceptually as exposure more broadly. And so again, we could do a whole other talk about the executing the steps of exposure, but to keep it brief so that we can really save our time to talk about the tailoring piece, Here we'll present a checklist that we've created to help give an overview of the basic steps that one might typically take in an exposure session. There's certainly some variability within this. This is sort of a loose guide to think through what the sort of major things one might need to do in a given exposure session. So first thing you might do in a given exposure session is briefly review a fear hierarchy and then collaboratively identify a task or exposure practice that you're going to do in session with the client. You want to work with the client to understand what their feared outcomes are if they complete that given selected exposure, and then really make sure to identify what the goal of this specific exposure practice is, because that's really important for knowing whether the exposure was a success and helping kids see that they've been successful in boxing back their anxiety. And in this process, you want to be really explicit about identifying what your goals are related to potentially minimizing rituals, whether you're trying to delay or minimize use of safety behaviors, like trying not to engage in sort of fidgety behaviors with your fingers, or moving your shoulders up to your ears and keeping them down nice and relaxed. There's lots of different ways that you can titrate that exposure based on those hierarchies that we've developed earlier. And then we would go ahead and coach the child to engage in the exposure practice, and we can use anxiety or SUDS ratings throughout the exposure to really help maintain a client's focus on the exposure task, and also kind of assess how difficult the exposure is for that child in the moment, so that we can adjust as needed to either make it more or less difficult. And all the while, we want to keep our eyes out using those assessment tools that Hannah mentioned, so we can try to minimize safety behaviors and keep kids engaged in the exposure task. Once the exposure is completed, we want to engage in what's called post-processing to really help the client process their experience, help them, if they met their goals, sort of see that they've met their goals, and ask questions to help facilitate learning in the client, to help them learn that they're able to tolerate and manage their anxiety and maybe do more things than they thought that they could. There's lots of questions we can use in this context of post-processing. We can compare SUDS ratings from the start to the end of the exposure. We can ask how the feared outcome was versus whether that actually happened and what the experience was like. One of my favorite questions to ask kids is, were you surprised that you were able to do that, and really sort of help them boost their own self-efficacy and confidence in handling things. And then ultimately, we also want to make sure we're building in some type of reward for completing the exposure task, whether that's something material or even a lot of verbal praise from the therapist. And then ultimately, we want to then assign an at-home exposure task, which is the sort of last critical component of the exposure frame, which brings us to homework and relapse prevention, which is our last step in this 5-step model. So home practice is a very critical component of exposure therapy that is uniquely associated with improved outcomes for kids. And conducting exposure practices in the sessions is important and critical for success, but it's likely insufficient for the skills to generalize to the places where they matter most, and to support the maintenance of gains after treatment has concluded. And so supporting kids to engage in intentional exposure practice between sessions, not I accidentally did something brave and I want to tell you about it, but really going out and intentionally trying to face their fears between sessions, is very critical for effective delivery of exposure therapy and not to be overlooked. And then finally, throughout treatment, but especially as you begin to see improvements with kids, we want to really support kids and their families in thinking about how we can maintain gains long-term after treatment has ended. It can be really helpful, excuse me, in this process to really normalize for clients that anxiety can be chronic, and that ups and downs with our emotions, including anxiety, are to be expected and are not always indicative of the fact that treatment has stopped working for them or that their skills aren't effective anymore. And in this line, we really want to help prepare kids and their families for the fact that anxiety likely will come back in the future at some times, and help them prepare for how they can manage that anxiety in the future and really be their own therapist moving forward. And in this process, we want to help clients also learn to embrace what we call an exposure lifestyle, or a lifestyle of approaching things that make us afraid, and emphasize the importance of really continuing to regularly practice and engage in exposures on their own to continue to manage their anxiety in the future. And of course, in this context as well, when we're doing relapse prevention work, we also want to continuously be celebrating and helping youth recognize their successes. So that's very quick exposure 101. And now I'll turn it over to Hannah to really get into the meat of what we want to talk about today.
Yes. So now that we've reviewed that overall approach for treating anxiety, this is where we'll shift gears to talk more about tailoring treatment. And in particular, why this idea of if anxiety due exposure may be too simplistic for many kids. And this is coming from two people who absolutely love doing exposures. But we also know that it's important to slow down, consider whether exposure is in fact the appropriate intervention for a given kid at a given time. So there are some examples of presenting problems that might co-occur with anxiety or OCD that affects our consideration of whether exposure is appropriate at that time or appropriate to address a given set of symptoms. So we're always considering whether exposure remains the appropriate intervention approach. So for example, if there's legitimate danger, we wouldn't, and Emily alluded to this earlier, if a child is, there are a couple instances. One is if a child is afraid of getting in a car accident, we're not going to do exposures of having them get in a car accident. And if somebody is afraid of violence in their neighborhood, and that's a legitimate concern, we're not going to tell them to go for a walk in their neighborhood. So there are times when exposure is not appropriate and other times when it is, but we need to make adjustments to our approach. So in the interest of time, I'm not going to go through every single example, but please feel free to ask questions about any of these at the end if there's a specific topic you want to hear more about. To give a couple of quick examples, for if a child with ASD engages in repetitive behaviors, we want to assess, is this related to OCD or is it ASD related? If it's OCD, for example, then exposures would be appropriate. If it is, if it's not, like let's say it's some sort of OCD just right ordering, then we would do exposures. If it's sort of more of an ASD specific process, exposure might not be productive to change that behavior. And there's also a question of, is that behavior functionally impairing or distressing? And do we need to address it? So that would be one example. Another example of exposures are consistently bringing up self-harm urges, either because of the content of the exposure or just because of the distress associated with doing an exposure. That would be another time where we would want to make sure the person has sufficient skills to manage those self-harm urges before we intentionally elicit anxiety and distress. So again, that's not to say exposures are completely off the table, but we wouldn't want to just proceed full steam ahead without making sure there are other skills in place. And then we also talk a lot about differentiating between when fear is protective and when it's a false alarm. So for clients who've experienced racial stress or stress related to a minoritized identity, there's likely to be some legitimate and protective anxiety related to this or resulting from this. And so it's important that our exposures are planned carefully so we don't invalidate or ignore these experiences. So all of the concerns on the previous slide very commonly co-occur with anxiety and OCD, and yet the literature really doesn't tell us much about how to address these concerns. So as I said before, we know there's a lot of evidence for using exposure when anxiety and OCD are the presenting concern, and there are instances when exposure is really not appropriate for a given case or in a given moment. So in the context of youth with complex comorbidities and presenting problems, we want to always think about the best way to sequence or augment exposure. And we know that exposure is a really powerful tool, which at times can make it tempting to use for as many problems as possible. But there are some cases in which we may need to modify it or defer it depending on the case.
This is really complicated stuff, and clinical judgment becomes really key in many of these scenarios. There is really robust evidence that exposures can be very emotionally draining for a therapist, and that even for clinicians who have the very best of intentions to deliver exposures can get short shrift. So in other words, exposures can be easy for clinicians to avoid doing. And so it's a really careful balance. And to ensure that youth who can benefit do receive exposure, we're going to propose here that there are some guiding questions and principles that you can use to guide work with youth. And one of the simplest ways to think about this is to work backwards from what exposure is doing, thinking back to those psychoeducation slides that Hannah presented earlier in the cycle of avoidance, which is exposure is aimed at supporting adaptive approach behavior. And then from there, can we think about what, if any, treatment targets or areas of impairment that there are that could benefit from exposure? And focusing on the type of avoidance behaviors, that including rituals in the case of OCD, that youth are engaging in, that are leading to some type of impairment can help identify these treatment targets. And it's really important, as Hannah was alluding to earlier, to remember that these treatment targets must be focused on maladaptive avoidance, not avoidance that is functionally helping a child stay safe. So for example, a child who avoids going to a nearby park because they have a fear of gang activities when it is a hot spot for gang activities would not be an appropriate thing that we would want to target through exposure therapy. And when identifying potential treatment targets that are avoidance-based, we want to make sure to remember also that avoidance can take multiple forms and can be really subtle, which makes this tricky. People with anxiety may end up avoiding people or objects or places, which are kind of the most common and easy ones to see sort of visually as therapists, but they can also be of internal feelings or sensations, which is important to suss out really carefully. And finally, accommodation is important to mention here as well when we're trying to identify targets that may benefit from exposure. Think of it kind of as a special case of avoidance because it's most observed among loved ones who may engage in various behaviors like providing reassurance or changing daily routines to prevent children from experiencing anxiety. So this can be a really important treatment target within the context of an exposure lens. And just because avoidance-based targets have been identified also doesn't mean that in and of itself that a youth may benefit from exposure in a particular moment, or it may not be the right fit, especially with more complex youth. So we're now going to present a few key considerations to address that question of how do we think about when to defer or not do exposure at all for a given treatment target. So the first sort of concept that we'll think about, especially within the concept of case conceptualization, is what we would call case conceptualization driven deferral or sequencing. So how do we think about sequencing exposure, excuse me, following the use of other evidence-based treatment techniques? We have a couple examples up here of some very sort of grounded, empirically grounded case conceptualization driven deferrals. So these are things where a child may certainly have significant anxiety or OCD symptoms, but there may be good reason that you might not dive into exposure right away within the context of treatment. For example, if a child has more primary depression and is experiencing a lot of withdrawal, use of behavioral activation first to stabilize a child and try to lift the depression may be important before moving into exposure. Second, if a child experienced significant family or housing instability, it may be critical to do some case management work and get some stabilization for the family unit before moving into exposure work to address other anxieties. Sometimes it's also, as Hannah mentioned earlier, there may be ongoing suicidality or non-suicidal self-injury that may make the use of exposures not the right intervention at that time, and maybe potentially even iatrogenic if you went for them too soon. And then alternatively, we might want to think about using different safety planning interventions or drawing from dialectical behavior therapy to address the suicidality or NSSI more directly, and then moving into exposures later on. And then sometimes you get kids where you're maybe just not sure. Like we've had a number of kids in our clinic where it's not always clear whether a child is experiencing obsessions and compulsions or having auditory or visual hallucinations. And in those cases, sometimes that's where additional assessment or consultation with other experts may be really necessary before sort of finalizing or formalizing a plan to move forward with exposure. One of the questions that I sometimes ask myself or encourage supervisees to ask is also, are avoidance behaviors identified that you're seeing the primary concern for which a child is seeking treatment? And if no, and there are clearly other pressing treatment targets, deferral of exposure could very well be indicated. In contrast to deferral, case conceptualization-driven contraindications are times where there may be avoidance that's causing distress, but still may not be appropriate to treat with exposure. And these can really sometimes fall into a gray area and be difficult to decide. And consultation or supervision can be really, really helpful here when it's not clear if exposure is indicated or not for a given treatment target. And Hannah alluded to our text chain for exposure ideas before, but she's also one of the people that I'll go to if I'm just not sure whether I should treat this with exposure or not, because I don't always want to make those decisions on my own because it can be really tricky. So for a couple examples, is let's say you have a kid who has very clear intrusive thoughts of self-harm, but also is experiencing active suicidal ideation. Do I want to do exposures to engaging in self-harm when I know there's active suicidal ideation? Probably not. I want to wait to see if that suicidal ideation will resolve through other interventions and then potentially revisit it down the line. If an individual is reporting having intrusive thoughts related to their sexual identity alongside having a minoritized sexual or gender identity, I might not want to address that through exposure and instead might approach that in another way. If I'm not sure about the level of safety in a client's environment, right? If I'm not sure if a child's avoiding the park because it's truly a hotbed of gang activity, or that's the child's anxiety kind of coming through or shining through really, really strongly, it may not be appropriate for me to do exposure until I'm able to clarify that information. And also, it may be appropriate to not do exposure in cases where you really have clear concern for a iatrogenic outcome, right? If somebody becomes highly aggressive or experiences homicidal ideation when they're in kind of in that fight or flight mode, that may not be the right person to benefit from exposure. And it's important to note here that even if you have the presence of avoidance behaviors that probably shouldn't be targeted with exposure, that doesn't mean that there might not also be other behaviors that you could target with exposure, but it may be that these specific types of behaviors are probably best targeted with other treatment techniques.
Okay, so I will just briefly talk about these accountable justification-driven deferrals, which are basically times when it's clinically indicated and justifiable to do something other than exposure in that session. And so a lot of times we talk about, if somebody's coming in every week with a crisis of the week and that is derailing us from the planned exposures, which is really where the impairment is, then that might be a reason to sort of revisit your assessment, sort of revisit client's motivation. But if on a session by session basis, there are certain things that come up, we might just say for that session, it makes sense to address this higher order need. And so this could be things like basic needs not being met. If a caregiver refuses to participate in treatment or in that session, that was integral to the exposure. If there's a need for additional assessment, so that could be, again, going back to the hierarchy building, understanding we need to do that in order to effectively proceed with exposures. Concerns, sort of what Emily talked about, that exposure be harmful, but these might be more in a case-by-case basis of something else that's happening in the person's life. Let's say that you're doing exposures related to death, and there was recently a death in their family that wasn't related to the fear that they had necessarily, but just that means in exposure, talking about death has a different meaning. Sometimes there are other techniques that are more pressing, safety concerns, or maybe focus is on treatment termination and relapse prevention, but not in session exposure. So these are just examples of things where it doesn't mean we'll never do exposure in these scenarios, but it might be justified to defer exposure for that session. And then the final category here is case conceptualization driven planned augmentations. So this is times when that basic or classic exposure model that I presented earlier is not appropriate or sufficient to address a given fear or clinical presentation. So we're going to go through each of these in more detail in a moment, but I want to just present or introduce this idea that in addition to that exposure waiting for habituation idea alone, there are absolutely cases where we'd recommend cognitive restructuring for a client whose cognitions function as avoidance, or maybe for somebody who lives in really high distress, which drives their avoidance, relaxation might be an appropriate augmentation. Similarly, mindfulness might be a helpful adjunct to someone who has a lot of post-exposure rumination, has trouble letting go of their thoughts, to build that skill of noticing and letting go. And we alluded before to distress tolerance and crisis survival skills, which might be effective in the event of unexpected flooding. So for example, if an exposure turns out to be way too hard, which then leads to risk of self-injurious behaviors in SI, that's where we might want to build in those distress tolerance skills. So again, we're going to talk through each of these in the coming slides, but that's a quick overview of what we mean by these augmentations that complement the sort of classic exposure model.
And as we think about sort of developing the process of identifying how and when you're going to augment the classic exposure model, here are some guiding questions to consider in collaboration with kids and their caregivers to guide exposure practice and integrate other techniques as needed. So first, making sure you have a good understanding of asking, what is my client afraid of? And is this fear leading to that maladaptive avoidance that we've been talking about? And then importantly, in thinking about designing the exposure and integrating other interventions, what does my client need to learn to overcome this fear? And how can I design and implement exposure tasks to help my client learn this to the fullest extent possible? And so this is an area where, again, clinical judgment becomes really key. And we may also need to check kind of our own biases about what does and doesn't constitute either maladaptive or unhelpful avoidance. And just to give a really overly simplistic example, like I have a fear of heights. So I sometimes have a tendency to minimize that in others. And like sometimes you standing back from ledges is more adaptive than it needs to be, right? Or conversely, we may think that youth may need to overcome a specific social fear that the child just doesn't perceive as impairing at all. And this is where being really, really collaborative with the family, as well as other treatment providers on an individual's treatment team, whether collaborating with social workers or psychiatrists to really understand what this child needs to sort of reach their functional goals and live a life consistent with their values, is really important to understanding whether you should target something with exposure or and consider what other augmentations may need to take place. And so we talked about, Hannah alluded earlier, we have a couple common targets for augmentation that build on that psychoed assessment, hierarchy building, tailored practice, and homework and relapse prevention for these kids with more complex presentations for whom that might not be sufficient. And so we'll cover only a few of the most common ones with the caveat that this list is in no way exclusive, as we'll talk about cognitive restructuring and the use of coping thoughts, relaxation and mindfulness, distraction, allowing safety behaviors, and rewards. So moving into first starting with cognitive restructuring, you may have noticed in our initial exposure model as presented, did not place a big emphasis on engaging in cognitive restructuring, such as identifying anxious thoughts or thinking traps, and then engaging in evaluation of thoughts before exposure practice. That's because in general, it may not actually be necessary to support youth, and in some cases may serve to lengthen the time to have kids reach the sort of reduction in symptoms that we want to see. And I truly wish I could remember who to attribute to, because I take absolutely no credit for the phrase, but the idea behind this can be really summed up simply by the idea that in traditional exposure model based in CBT, so cognitive and behavioral therapy, if you do the B or the behavior, you'll get the C or cognitive change for free. So in other words, if you support youth to engage in exposure practice, the youth will engage in learning that will actually facilitate the same cognitive changes that one might achieve with more traditional cognitive restructuring. And along these same lines, doing too much cognitive restructuring prior to an exposure may limit the opportunities that a youth has to learn through exposure practice, that either feared outcomes may not come true as expected, or that they're able to handle much more than they expected that they could. In my own practice, I actually sometimes think of doing I think of this almost as like a cognitive sandwich. So prior to the exposure, I'm working to understand the anxiety a youth is experiencing and what they were afraid of, but then I'm not actually doing the restructuring. But after the exposure is over, we're engaging in that post-processing to really solidify that same content we might have identified if we had done something more akin to traditional cognitive restructuring like detective thinking. But this doesn't always work in all cases. And so how do you know when to do more traditional cognitive restructuring versus try to get the C for free? So sometimes you really do need to do the C to get the B. So for example, if kids have really intense anxiety that leads to outright refusals to engage in exposure practice, that may be a sign that doing some more traditional cognitive restructuring may be needed to kind of get kids more willing to be able to engage in difficult exposures. In addition, really thinking back to your initial case conceptualization and understanding of the child's fears, if there are very clear cognitive distortions that are central to presentation that the kid has, for example, if they have really high threat overestimation, like they're really overestimating how likely it is a dog is going to bite you if they're in the room with you, then integrating that more traditional cognitive restructuring prior to the exposure can be really, really helpful and potentially really necessary to see improvement.
All right, so I'll talk a bit about distraction and how the role of distress tolerance skills in that as well. So in that traditional model of exposure, I talked about, and we've talked about throughout, how avoidance and safety behaviors can interfere with learning and play a role in maintaining anxiety. And so we often think of distraction as being a type of safety behavior in which someone's avoiding looking at or thinking about whatever they're afraid of. And sometimes distraction can be behaviorally observed, so looking away, doing something else, or it could be mental, like having neutralizing thoughts. And related to this, on the topic of comorbidity, one thing we know is that exposures are often particularly challenging for kids with ADHD, especially inattentive type, when they have a hard time sustaining attention, which we think of as being core to habituation and learning. Sometimes we have to work with other team members like psychiatrists to have a stimulant or other pharmacological interventions to allow engagement with the exposure stimulus, because otherwise there is a lot of distraction that can happen and that can make it challenging. However, there are times when distraction is appropriate. So for one example, it might be part of a gradual hierarchy, and that's a pretty common thing, that if we're not getting the buy-in from a kid to do an exposure with full attention, perhaps we plan on initially doing an exposure with distraction. So for example, with a basic phobia example, let's say a kid has a phobia of the dark, and the idea of them sitting in a room, even with you, without doing anything, it's too overwhelming. Maybe you start by playing a game in a dark room, which allows some sort of attention away from the stimulus while also being in its presence. So there are many more examples of how we would do that, but that's just often a consideration on the fear hierarchy. Maybe you build in the distraction. Another one is, and I briefly talked about this before, people who have intense anxiety that leads to self-harm urges. This is when distraction as a crisis survival skill to get through the moment and not make things worse might be really effective. And then, so it's do the exposure. If it's too hard or self-harm urges arise, then you use distraction crisis survival skills to get yourself regulated enough not to self-harm. And then you can think about re-engaging either in the same exposure, maybe an easier exposure, or maybe not that day, but maybe another time. You keep that in mind and plan and titrate accordingly. So those are a couple examples where distraction and distress tolerance can play a big role in exposures. So the next thing is relaxation or deep breathing. So similar to distraction, relaxation has the potential to interfere with learning if patients rely on it to get through hard things. So if it functions as an avoidance behavior, every time I'm anxious, the only way I can get through it is to use relaxation, that can get people stuck in the cycle of avoidance. And there's evidence showing that exposure alone is effective, and that the addition of relaxation doesn't add anything in terms of improving outcomes, and sometimes even results in worse outcomes. But of course, this is on average. So there are also times when relaxation is really effective for individual patients. So for instance, for some people, it may enhance exposure, tolerability, and acceptability for both the patient and sometimes for the therapist too. Often when we're training therapists who are really reticent to use exposure, especially with complex cases, we basically say it's better to do exposure with relaxation than to avoid it completely, even if you know eventually I want to get this client to do exposure without relaxation. It can be an effective way of titrating for the patient and therapist. Another thing is similar to sort of that crisis survival kind of situation. Using relaxation to help stay in the moment if a patient is flooded or the exposure was, just unexpectedly too hard, it can be helpful to use deep breathing to get them to stay in the situation and not do a complete avoidance, right? So if we think of relaxation and deep breathing, they have some impact on that quick drop in anxiety. What we would rather do that than have them run out of the room if it's a dark exposure, for example. Another one is reducing overall distress. So if I have clients who sort of walk around in the world outside of exposures just with really high baseline levels of distress and anxiety, I often say, relaxation, deep breathing when you're just walking around and having a hard time staying in the moment can be really effective to help you just manage those high levels of anxiety. And another one is I often talk about the different reactions that people have to anxiety, and there's sort of the traditional looking anxious and fearful response. There's often a tearful response, and there's often an anger response. And some people, when anxiety comes up, they respond with anger. And so in those cases, instead of yelling or throwing a temper tantrum, that's when it absolutely might be more effective to use deep breathing as an emotion regulation strategy rather than engaging in that fight anxiety response. And then finally, mindfulness is certainly different from relaxation, but I just want to make a quick note that this idea of maybe focusing on the breath as part of mindfulness, the intention is not relaxation, but it is another skill that can be helpful to bring attention to the current moment, keep focus, let go of judgments, and is often, of course, a really helpful augmentation to exposure for a lot of people. So by now you probably realize this is going to follow the same logic as distraction and relaxation, which is again that part of the anxiety curve that is that quick relief. And safety behaviors often or do function the same way, but sometimes allowing them is appropriate. So safety behaviors can basically be anything that the youth or the caregiver perceives to help them lessen anxiety. So maybe it's that if an adolescent goes out in public, they have to have their cell phone with them so that if they're waiting for somebody alone, they can look at their phone and not look weird, right? So having their phone or looking at their phone might be a safety behavior. Maybe it's having a parent nearby in new situations, just for the familiarity so that it's less new. Maybe it's carrying a lucky rabbit's foot to avoid having a car accident, right? There are endless ways that people can engage in safety behaviors. And the problem is that people rely on them and then that they learn that they can only handle the hard things if they do the safety behavior. So again, that's why, and these again can be overt or covert. They are often logical, sometimes they aren't. But the point is that we know that using a lot of safety behaviors can reduce the efficacy of exposure. On the other hand, in some instances, it is effective to allow that. So we're really thinking about, does this let the person move closer to what they're afraid of? So if they have panic disorder and depression, and they have a safety behavior of only going to places where they can park close by, it might be preferable to have the person keep doing that safety behavior and going places and parking nearby rather than, do that behavior with the safety behavior rather than reducing the safety behavior, especially if it also is an opportunity for behavioral activation and is treating their depression. So again, we always want to think about, we don't want to be black and white with reducing safety behaviors. We want to think about what is the long-term goal? How does this align with what we're trying to get them to, and how does it fit with their other symptoms? And yeah, I will stop there on that one in the interest of time. So a brief note about rewards. Emily had put a quote up about this earlier about that I'm only with families for about an hour of the week, and most of the active treatment really happens outside of the therapy room. So it's pretty much always important to reinforce brave practice, even for adults. And there's often a need for flexibility about what rewards look like. Ideally, they should be given, they should be desired, they should be given consistently, and really importantly, especially for anxious kids, in response to effort and not results. We also find that rewards are especially important for kids with inattention and hyperactivity. On the other hand, I have really quickly, I'll say, worked with kids who say, I don't want rewards, or I don't like the attention. And so I think it is important, while we say, yes, reward, reinforce all of that, I at least want to be checking in about it and making sure the motivation is there. So again, that's all I'll say about that for now. So to wrap us up, this question of what if exposure doesn't seem to be working is one we often get asked and think about. So I want to highlight some of the reasons that when exposure isn't working, we often think might be underlying that. So I talked at the beginning about core fears. We try and assess them at the beginning, and sometimes we get them wrong, or sometimes they change. And so sometimes if you have the wrong core fear, maybe a kid has been having a hard time separating from dad. And so you've been focusing on separation anxiety, assuming, they're afraid when they're away from dad, something bad will happen to them, and things aren't improving. Maybe it turns out that it's actually social anxiety, that if dad is nearby, they are okay with talking to people, but as soon as they have to be away from dad, it's suddenly so scary to talk to people without being able to look back at him for reassurance. And so maybe you started doing exposures thinking the core fear is separation, and the real core fear is actually social anxiety or rejection or embarrassment. Another reason that exposure might not work is white knuckling. So I recently worked with a kid who white knuckled her way through a summer camp that involved performances, and she did all of the things, and she, checked off all the boxes the whole time. She was at a 9 or 10 out of 10. I was just terrified the whole time. She got through it, but what she learned was that it was awful and she couldn't tolerate it. And so that was sort of like, school had also been really stressful, and she had done the same approach. And so sometimes when people are white knuckling their way through exposure, they don't actually have that habituation or learning. They just have this belief of it gets hard, it stays hard. I have to feel miserable to get through this. And that is usually not an effective way of promoting learning. A couple other things discussed is sometimes central to the presentation rather than fear. So that's important to assess for. Of course, motivation is key to getting exposure to work. I talked about inattention, making it hard to do exposures if you can't focus on the task. And then again, Emily talked about caregiver accommodation, and caregiver anxiety often arises too, making it hard for parents to implement exposure or to model brave behavior. So that was our sort of rapid fire tour through all of this. And we can now, it's exactly 1 o'clock, but we'll stick around for a little bit for any questions. Thank you all so much.
Thank you so much, you guys. I will just grab this share screen from you real quick. We do have a few questions that came in, and if you do have any other further questions, please feel free to email me at essacard@adaa.org, and I'd be happy to send them over to our presenters. So we do have one question that someone else was interested in, and they want to see if you can discuss Lyme disease induced OCD, sorry.
Yeah, this is actually not something I haven't had any patients with it, unfortunately. I wish I were able to be more helpful on this. I don't know about you, Emily.
Yeah, I haven't seen that. What I would recommend, though, and when I think about doing this with other medical complications, is trying to talk to the physician who's diagnosed the Lyme disease to get a sense for whether ERP would be contraindicated. So sometimes, like if kids have panic attacks, you want to do interoceptives, or kids have cardiac issues and panic attacks, like I want to get approval from or speak with the physician to get a sense of like what I can do reasonably and what I might need to be cautious with. So I think that collaboration there to get a sense for what the physician thinks is going on and whether or not it would be safe and appropriate for an individual to engage in OCD would be really critical there.
Great, thanks so much. And we had another question that was, when would you do ERP without using a hierarchy?
That's a really good question. Hannah, do you want to take that one first?
You can go ahead.
Well, I'll offer my thoughts and I'm sure Hannah would have more to say. So I don't often do a formal hierarchy at this point, but I've been doing this work now for over a decade. So I feel pretty confident in my ability to sort of suss information from the first few sessions and just really dive into the exposure practice. I think you wouldn't want to not use a hierarchy until you feel very, very confident. I sometimes think about it as like, you can turn on a faucet and it will have this like drip, drip, drip trickle, which is how it used to feel for me to come up with exposure ideas. And I really relied on the hierarchy and working with my supervisor to figure out what I should do next and how to do it. And then at some point, I don't know exactly when, but it turned into a faucet. And all of a sudden I felt like I could come up with exposure ideas like really, really quickly in the moment. And like when that happened, I found myself pulling away from the use of a hierarchy because I could quickly titrate in the moment. So I think it really comes down to how confident and comfortable you are with being able to dive in. And I wouldn't do it after you've had a lot of sort of experience and supervision. But Hannah, I don't know if you would say something different.
Yeah, I would just add to that, which is that I think it also depends on the client. I have a client right now who is really not experiencing a ton of habituation, but she's sort of more willing to do exposures. And so I think with her, I have not created a really formal hierarchy because one, she gets exposure enough to understand herself some of the titration. And two, because she's not experiencing like really clear habituation every exposure, I don't want to put too much emphasis on this one's higher, this one's easier. It's more driven in this case by what are her values, what are her goals, what's hard but doable. So I think that's just another example of when I wouldn't have a formal hierarchy.
And one other thing I'll add to that reminded me of that, thank you, Hannah, is that the hierarchy is a guide, but we don't necessarily like do one and then do the next one and then do the next one and then do the next one. It's really to get you your roadmap that you would then move forward from. And we want to try to introduce that variability into exposure practice when possible. And one way to do that with kids that I really like is making like a bingo board. So instead of like taking a bunch of exposures that we think a kid is probably ready for, arranging them on a bingo board, and then having kids try to get bingo to earn prizes can be a nice way to sort of use the loose structure of a hierarchy, but not feel bound to the sort of steps nature of what a hierarchy, sort of a traditional hierarchy, can kind of provide.
All right, thank you so much. I would like to just take a moment to invite all of our attendees to sign up for the next upcoming webinar, which is on psychoeducation and resilience on August 26th. And if you are not yet an ADAA member, we invite you to view our many membership benefits that ADAA has to offer, including free CE webinars such as this one. And I want to thank our wonderful presenters for joining us today and all of our attendees. Again, this webinar will be available on demand within 24 hours. And if you have any questions, please reach out at sicard@adaa.org. Dr. Frank, Dr. Becker-Hames, thank you so much for joining us today.
Thank you for having us.
All right, have a great day. Thank you.
Thank you.